Okay, so hopefully I can make this work. Terrific. So we're delighted to join you and really excited to have not only all of you on the line, but also colleagues from the Department of Health. So hopefully we'll be able to talk about not just sort of the context of testing from some of the national guidance, but also how that's being implemented locally. Going to talk, and there are probably more slides here than I want to really spend time talking, but I want you to have that as reference points. But we'll look a little bit at the different testing options, apply or consider some of the different guidance and how you walk through those, and some considerations for interpretation of tests, especially as we're learning more about how they perform. And I often start with this figure when I talk about testing, because it helps me to sort of visually see how tests are how they're performing across the course of somebody's infection with SARS-CoV-2. So to the far left, there's a window of time when somebody's been exposed and maybe incubating the virus without any symptoms, and you can tell that there's a window where no tests are really going to pick up this infection, and it's not until closer to that dotted black line that's showing the beginning of symptoms onset that you start to see the viral detection from molecular tests in the blue line, that's the PCR testing of respiratory samples, start to go up and become positive. And then you start to see towards the far right of the graph, these dotted lines come in, which represent the immune system's response to the virus. And those antibodies becoming detectable really coincide with the viral detection coming down. And there's a bit of a delay between when somebody is symptomatic and has detectable virus present in samples to when their immune system responds to that. And that's one of the reasons why the antibody testing or serology tests aren't really good for detecting new clinical infection. And that's one of those, when you're selecting tests and what are their purposes, that's an important point. Now, this graph came out in a publication that was published before the antigen testing platforms were really out and in wide use. So we don't see the kind of curve that we might detect with the antigen tests, but they are authorized for use in the first 5 to 7 days following the onset of symptoms. So their curve is going to be similar to, but maybe a little narrower to the molecular or PCR testing curves. And here's a table that just sort of puts all of these different test types in one shot. And I put a box around the viral detection tests because those, again, are the ones that we use when we're trying to determine if someone has active illness and could be shedding virus and potentially communicable. And one of the, so the serology tests representing the immune response to that right now can't be used for just identifying new clinical infection. But the other thing about the use of those tests is until we have a better understanding of the role of our immune system and the protective effect that it may confer, we're really not able to exclude people from testing for virus, whether it's in response to an outbreak or if they have new symptoms, just because they have a positive antibody test in the past. So right now, anybody, regardless of their serology status, would still be eligible for testing if appropriate, viral testing. And then drilling down a little bit more to those viral tests, the molecular platforms, which are the polymerase chain reaction or PCR tests, which are really detecting the genetic material of the virus. The antigen tests are detecting proteins that are on the outer surface of the virus. And on this table that sort of compares those two a little more closely, I've put a box around the sensitivity and specificity characteristics of these two tests and the differences between them. This has come up a lot as people are looking at how these tests perform, and just to remind ourselves what these terms mean. The sensitivity of a test tells you how likely it is that somebody who has the illness, who has SARS-CoV-2 infection, will have a positive test. And so the higher the sensitivity, the more we trust that the test will pick that infection up. If you start to have lower sensitivity, that's where you worry about false negatives. You're missing people who actually have the infection. And that's one of the differences between the molecular PCR test and the antigen test. And specificity is how well a test performs when you don't have the infection, that you get a negative test. So here, if you have lower specificity, that's when you worry about getting more false positive results. So with that in mind, we'll talk a little bit later about how that those concepts and the fact that the antigen tests have a little bit different sensitivity compared to the molecular tests when it comes to interpreting results. The two big ways that I think about using tests are either for diagnosis, and really that's when you are looking for current illness, or you're looking for potential spread of virus due to exposure. So diagnostic testing is used for people with new signs or symptoms consistent with COVID-19, or when you have asymptomatic individuals with known exposures. Screening is done when we are looking at a group of people who don't have any known exposures, and we're doing kind of regular testing of those folks to find unrecognized asymptomatic infected individuals, and to sort of be able to exclude them from the center before the virus could be introduced into the center. And this is the principle that's being applied with the recommendation for regular testing of healthcare staff in centers. And these kind of strategies are outlined here in the three different ways that we recommend testing in nursing homes right now, right? Diagnostic testing for symptomatic individuals, whether residents or healthcare personnel, which should happen very quickly as soon as symptoms are detected and concern of illness is present. And really, the faster we get those results, like your colleague who just put in the antigen testing platform on site, really helps to bring that turnaround very quickly and have fast implementation of infection prevention measures from that result. Outbreak testing is triggered as soon as a new case is confirmed in either a healthcare staff member or in a resident. And then that non-outbreak screening, which really is primarily serial testing of staff based on the prevalence and county positivity of COVID-19 in the community, which kind of dictates how frequently that testing is done. And just to talk a little bit more about the responding to a new case and how, the immediate deployment of outbreak testing, really the initial recommendation is that you look very broadly, right? When you have a new confirmed case or in a resident or staff person, you want to test pretty much everyone else to see at baseline if there are other infected individuals. And then there's ongoing repeat testing of those folks who were negative until you get, and it's really ideal to do that repeat testing on a fairly aggressive interval. Every 3 days is optimal. It can be up to, every 7 days, but especially in those first 14 days following that initial case, that, remember, is that incubation window where people could be harboring virus and not yet manifesting symptoms. And the goal of this very frequent testing is to find those folks when they're still asymptomatic or pre-symptomatic, so they haven't started developing illness, but you're able to respond to their infection and move them into a cohort like a designated COVID care unit, or have a staff excluded from work while they're recovering. And that outbreak testing is recommended to continue until you don't find any additional cases for at least 14 days from the most recent case that's detected. So then you've gone beyond that 14-day window, and you're likely to have found you've likely to contained that that spread. So when you have the capacity, the supplies, and the availability of testing resources to do this, the broader you can do testing, the better, because we have seen that sometimes people can move when they're asymptomatic and spread the virus to other parts of the unit, other parts of the facility, without really being recognized. And those delays can allow those infections to spread more in your building. However, if capacity is limited, then you can focus the testing and the serial testing during an outbreak to the highest risk folks with known exposures and the people who are the most likely to be affected where cases are being recognized. And this is just a figure to illustrate from some data that we've compiled from over 90 centers working with health departments across the country that were looking at how many new cases were identified when they did facility-wide testing following the first case in their building. And the average time it took from the first case being identified to doing that broad facility-wide testing was 7 days, but you can see a pretty broad range. Some centers were able to do it within a day or two. Others took several weeks to over a month. And what this analysis showed was that for each extra day that it took from the first case to doing that broad facility-wide testing, you saw a little over one case extra occurring when they finally did the testing. So the longer that it took to do that facility-wide testing, the more new cases of SARS-CoV-2 infection were identified in the centers. And so if we can do it very quickly and do it on a more frequent interval, that's how we can minimize the spread and really contain those outbreaks. Some of the questions that have come up as centers have been deploying this kind of testing strategies have been, well, what do we do when we have somebody who has recovered from COVID? And, how do we address the fact that sometimes even after somebody is better and their infection has resolved, they can still have viral particles detected. And this is particularly true with the molecular, the PCR test. We saw that quite a bit. So as we have learned more about the arc of illness and infection, we have found that within the first 3 months following recovery of the COVID-19 illness, there isn't a need to quarantine or retest somebody for SARS-CoV-2, whether it's during an outbreak response or if it's part of your staff screening protocol. And that is because we've had enough experience to see that these folks are likely not shedding virus that can be spread to others. However, as we're still trying to understand the level of protection that comes from recovering from this virus, at this point, once people are beyond that 3-month window, then if they happen to be tested as part of staff screening or because of an outbreak response and expanding your testing, in that circumstance, if they have a new positive, they should be handled as if they might be infectious and placed in isolation or have staff excluded from work. And as we generate more data and have even more understanding of the duration of protection and how individuals recover, we may learn that we can push this length of time even farther out. But this is where we are right now with the information we have. The other time when you might need to retest somebody who is recovered from COVID-19 before that 3-month, within that first 3 months of their recovery, is if they develop new symptoms that are consistent with SARS-CoV-2 infection, and especially if you don't have any other explanation for those symptoms. And that in that circumstance, if the person does test positive, it's recommended that you handle them as though they have infection and potentially could be contagious. So placing them in full precautions until their symptoms resolve and they go the adequate time. So the other thing that has come up a little bit as centers are deploying the screening programs for their healthcare staff is, well, what about for residents? Should we be doing regular screening testing for our asymptomatic residents? And right now, the honest answer is we're not sure. There may be some benefits, especially for residents who may be regularly leaving the center and, for example, going to dialysis or chemotherapy treatments a couple of times a week, right? That potential exposure from coming in and out of the center could create a different level of risk, especially if you're in a community where the SARS-CoV-2 virus is spreading at sort of moderate to high rates. However, the uncertainty and the sort of downside of doing a testing on a regular basis for these folks is that you may have a higher risk for false positives, and that can actually trigger a lot of additional unnecessary testing. So we are still gathering data and learning from you, and would be very interested in hearing your thoughts on this and whether you're exploring the use of testing in this way to better understand just where is that best balance for protecting residents while not creating a situation where a lot of testing is done without need. The other thing I wanted to talk a little bit about was just some guidance that we had posted, I guess it's about a month ago now, looking at how to deploy the point of care antigen test and how to interpret the results from those tests, basically looking at 3 different scenarios. One is when you have somebody with symptoms, and so you're doing that diagnostic testing. The next is if you have people who are asymptomatic, but but they're getting tested because of a recent exposure, so they're at a higher risk, and you're doing that outbreak testing. And then the third scenario is when you've got that routine screening of asymptomatic staff. And what I've kind of highlighted in the red boxes on this slide are the 2 places where we would recommend confirming the result of the point of care antigen test. So on the left side is when you have somebody who's symptomatic and they get a negative point of care antigen test. In that circumstance where you have a high clinical suspicion that they could have COVID-19, but the antigen test is negative, that's a circumstance where we would recommend you do a confirmatory test, usually with a higher sensitivity. Remember, the molecular tests like the PCR are the ones with a higher sensitivity to double check that result, because it's not what we would have expected. And the other place is toward the right side of the graph when we're looking at asymptomatic screening, testing for screening, and you get a positive. And in that circumstance, you look at the other situation, the other factors that weigh in at the time. So if I'm in a low prevalence community, I have not got any cases in my building, and there aren't that many cases in the area around me, a positive antigen test may actually be a false positive. That's a possibility, and that's another circumstance where doing a confirmatory test with another type of test, like the PCR, is recommended. And we can come back to this and talk about it again if people have more questions as we think through, how to apply that. But why could you get unexpected results from these tests? Earlier, when we were talking about just the characteristics, the sensitivity and specificity, those are factors that are sort of part of the test itself. But there are all these other things that we also should consider, starting with how well did we collect the specimen? These are not comfortable tests to experience, and so people very fairly sometimes kind of pull away, and if there isn't a good sample collected, then that could affect how well the test detects virus if it's there. Mishandling or sort of having delays in the time from when the specimen is collected to when it's put on the machine, or any kind of storage problems in between, like if you have to store it and then send it out to a lab, those factors can also contribute to the accuracy of the test results. That's why it's so important to have people who are really comfortable, trained, feel proficient, and have know how to handle the specimens, have the time and the space. Risa was talking earlier about how they created a whole room to run the test and have regular clean surfaces, follow the protocols for cleaning and disinfecting the machine so that there isn't contamination of samples when they're being handled. All really important things to double check when you're concerned about the results. And then using the quality controls the way the manufacturer of the test recommend, especially when you have somebody new who's just learning how to use the test. This is a way to check their proficiency. Or if you get a new lot of kits, a new supply of kits or reagents. Talked a little bit about how the clinical presentation at the time of a test, like whether somebody has symptoms or not, is a part of the decision making in interpreting a result, as is how much COVID-19 or SARS-CoV-2 is really around in my center, in my community at the time I'm doing the test. So these are all things that go into interpretation. What do you do when you have to wait and you're not sure about the result? When you're doing confirmatory testing, either because you're not sure about whether something is a false negative or a false positive, we would recommend maintaining the full infection prevention measures, whether it's excluding an individual from work or placing a resident in precautions, until you kind of sort that out. Now, one caveat is we would place somebody in precautions using full PPE during their care. But if you are uncertain about the test results, then you don't want to move a resident to your dedicated COVID care unit until you've confirmed it. And that's just to be as safe as you can. If there's any question about the test result. Talked about using a confirmatory test that's got a little higher sensitivity, and you really want to do the test as quickly as you can after the initial antigen test, just so that it reflects the same circumstances. Sort of, if you go a few days before you send that confirmatory test, now the situation with the viral detection, et cetera, may be different. So that's why the confirmation test needs to happen very quickly. And if you are in a circumstance where you're questioning a positive antigen test, you're in a low prevalence, low risk asymptomatic person, then we recommend sort of delaying additional expanded testing until you get that confirmation, unless there are new symptomatic individuals popping up, and then you really want to talk with the health department, kind of think about the whole situation to determine how to proceed.